My name's Chris Shamana. My background, I'm a cardiologist that specializes in advanced heart failure, meaning after my fellowship, went on to do further training to look at advanced heart failure, heart transplant, mechanical circulatory support, what we call like LVAD therapies. So those are my focuses in my day-to-day practice. I also have a special interest in practice in pulmonary hypertension, cardiogenic shock, as well as a specific genetic cardiomyopathy we call hypertrophic cardiomyopathy. So again, big topic here, chronic heart failure. I think we're going to kind of give you kind of the overall look at things on how at least I generally approach this condition that you guys are going to be coming up against probably every day in your practice. Some basic facts about heart failure. I mean, why do we care about it? It's common. There's anywhere estimated between 6 to 8 million people within the country that have this diagnosis. It's very expensive. We spend more than $30 billion a year on it. A lot of people are in the hospital, over 1 million hospitalizations a year. 25% of those individuals actually are readmitted to the hospital within 1 month of their initial admission. And then why particularly I really care about it also, and hopefully you do too, is that it kills a lot of people. Over 300,000 deaths a year. And the mortality rate is pretty significant. In 5 years, 50% of people that have heart failure will be dead. So that's why we should care about it. You're going to see it. These are sick patients and they can be very complex. So if we break it down a little bit, first answering the question, well, what is heart failure? I like this from the old American College of Cardiology guidelines. This statement here is that it's a complex clinical syndrome. And it's a clinical syndrome that results from any structural functional impairment of ventricular filling and or ejection of blood. So it's a clinical syndrome. The ventricle has an issue with either filling and or ejecting. In some ways, I can kind of think about it as basically from the pathophysiologic standpoint is something first happens to the myocyte. So the myocardium is affected, whether this results in myocyte dysfunction or necrosis and loss. And as a result of this, the ventricular pump function diminishes. Because of that, of course, makes sense, your cardiac output would decrease and blood pressure can be affected as well. And the body, as you see, will have this response to this. And so one of the things we see is first off is sympathetic activation. And with the activation of the sympathetic nervous system, in the short term, some of these things are really good, right? If you have an acute MI and your pump function goes down, well, you'd want your heart to try to squeeze faster and beat harder in order to increase that sudden loss of cardiac output. And so sympathetic activation with increasing things like norepinephrine, dopamine, epinephrine, et cetera, are good things in the short term. Likewise, as the kidneys get hypoperfused, the renin-angiotensin-aldosterone system is activated. So you can get vasoconstriction, so better end organ perfusion, as well as sodium and fluid retention in order to optimize the preload in the ventricle. Inflammatory cytokines are released. And then you also are going to have the wall stress within the ventricle to optimize the Frank-Starling mechanism. You start secreting natriuretic peptides. So again, in the short term, these are good. They affect our afterload, preload heart rate contractility, and therefore our cardiac output. But the problem is that if this is occurring chronically over time, we actually develop maladaptive responses. So the ventricle can start to hypertrophy, it can dilate, you can develop valvular dysfunction, dyssynchrony, arrhythmias, and which cause more myocyte loss dysfunction. And as you can see, you just get this cycle that goes over and over and over again. And so we need to find a way, especially in the chronic scenario, into using different therapies to combat this long-term maladaptive response. I'm not going to go through everything here and the signs and symptoms of heart failure, but these are just, I think, some good things for you guys to make sure that you have in mind when seeing and evaluating your patients. Commonly, the most common symptom that patients have is shortness of breath. Most of the time, especially in more mild and moderate disease, this is only when they exert themselves. So you can't just look at them and see if they are having shortness of breath. You need to investigate and ask them how far they walk and what they're capable of doing. But as severity happens, they can have resting dyspnea, orthopnea, PND. Swelling is extremely common. This is pitting edema. Classically, it's bilateral lower extremity. The severity of that depends on each individual, abdominal bloating, fullness. They can develop arrhythmias and they can pass out from this. If they have defibrillators, their ICDs can start shocking them. One way we can classify individuals based on their symptomatology and limitation is something called the New York Heart Association, or the NYHA heart failure classification. And this kind of just gives us an idea on the day-to-day of what our patients are capable of doing. And so class 1 would be absolutely no limitation, where on the very extreme of class 4 is going to be somebody that has severe limitation at rest and symptoms, and then everything in between. And this also can be a measure for us, as our patients come to us with this problem and we get them on therapy and optimize them. Our goal is to bring them from 3s to 4 back to hopefully 1 or at least 2. When you examine your patients with heart failure, things you're going to see, of course, weight gain. This could be from the edema and the fluid retention. If they're really not perfusing, they can actually be lethargic or you can seem confused. Examining, of course, listening for rales, checking for edema. One, I think, of the very important things in a skill to practice is assessing the jugular venous distension. And when you lay the patients down at 45 degrees, you can look at the internal jugular vein, and depending on the height of the pulsation of that vein, it gives us an indirect measurement of the pressures within the heart. So as the pressures go up into the ventricle, that pressure backs up into the vein and that pulsation increases up on the neck. So how do you finally make the diagnosis of heart failure? I think this is part of the fun part for me is it doesn't come down to just one diagnostic test. This is where you need to be the detective. So it's not just based on an echo. It's not just based on an NT-proBNP. Here you need to sit down, you need to talk to your patients, you need to examine your patients. And these other tests like the chest x-ray, the echo, etc., are supplementary to it. But there is not one individual test that can completely rule in or rule out heart failure. And this can be tough. I mean, you just heard about COPD exacerbation. And so, there's a lot of things out there that can cause shortness of breath. And so these are just some of them, right? We have all the different pulmonary etiologies that we need to make sure we rule out, other things like anemia, deconditioning, anxiety. There's a lot of other cardiac issues also that can cause heart failure. And so taking this whole picture into approach and ruling out other etiologies is important first when making this diagnosis as well. So kind of my general overall approach to the management of heart failure, I think if you go by the next couple bullet points, you should do pretty good. Number 1 is making the diagnosis. Number 2, once the diagnosis is made, do your best to try to determine the etiology that's causing their cardiomyopathy and therefore heart failure. And the reason I say this is because there are certain etiologies that may alter the treatment. You want to treat that underlying cause. For instance, if they have a tachycardia-induced cardiomyopathy, what would be very important for us to treat the tachycardia, and then on top of it, we would use alternate therapies as well to treat their heart failure. What's next is important too is that we classify and grade what their left ventricular ejection fraction is. And I say this because the therapies that we have available, whether they're medical or device therapies, have been shown through multiple randomized controlled trials over the years to either be beneficial or not, depending on the ejection fraction. So having an accurate EF assessment is very important. You also want to determine if your patient is quote unquote compensated or not. And I mean by that is that this is a chronic disease. And so what will happen in individuals is we want to look at them and see is, are they at that stable condition? Are they at the best that they can be with our therapy? Or have they had a decompensated state having worsening heart failure or new on heart failure? And the reason that's important is because we may adjust some of the therapies that we do accordingly. We then, of course, want to get them on therapy. And as we treat their therapy, we continuously reassess and optimize the therapy as much as tolerated. And what's also important as we assess these individuals is having an idea of where they are on the long-term progression of their disease, and which we'll talk about a little at the end. So some of the different things and ways we can classify cardiomyopathy and etiologies, there's a lot of schemes out there. I wouldn't recommend just memorizing every single one of them. This is one way you can broadly look at cardiomyopathies. You can look at genetic causes like hypertrophic cardiomyopathy. You can look at acquired things such as inflammatory, like myocarditis, or stress-induced cardiomyopathy. And then there's the mixed bag. There's also secondary cardiomyopathies. You can have systemic diseases that result in cardiomyopathies. Another way we can look at it is you can kind of break it down into, is it an ischemic or non-ischemic etiology? Roughly 40 to 50% of individuals with heart failure have coronary artery disease that's the result of it, or that results in their heart failure. The other individuals, there's kind of a laundry list as you can see here. But again, some of these things would be very important, right? If somebody has alcohol cardiomyopathy, well, quitting alcohol would be important because you actually may get some improvement in their LV function. When we're classifying or when we're grading their ejection fraction, this is most commonly done by echocardiography. And what I'm showing you here is just kind of two extremes. So this right here, this chamber is the left ventricle. And as you can see, remember the ejection fraction, or the EF, should roughly be around the 60% range. And I think everybody hopefully can agree that it looks like from diastole to systole, it looks like we're squeezing at least 60% of the blood. So this would be a normal EF compared to on the right here, you can see a severely reduced ejection fraction, probably closer to the 20% range. We have ways of measuring this on echo. We can actually take still frames in different views. We can trace the myocardium, and the computer actually will calculate an ejection fraction for us. So we do our best to assess what the ejection fraction is, and then we broadly will put them into these categories. So if the ejection fraction, if somebody has heart failure and their ejection fraction is 50% or more, we call that heart failure with preserved ejection fraction, or HFpEF. If you're in the 40% range, this is mildly reduced ejection fraction. And then if we're 40% or less is what we call HFrEF, or heart failure reduced ejection fraction. And you'll see that a lot of the therapies, devices and medical, have been shown to have benefit in the reduced ejection fraction population, unlike the HFpEF. And then there's this other class called improved ejection fraction, where you were once HFrEF and now you're not. And these come in all different flavors. These are just a couple examples of different ejection fractions and etiologies of heart failure. You can see on the top left here is a young man that has Duchenne muscular dystrophy that's resulted in cardiomyopathy. It's ejection you can see the left ventricle is severely dilated and probably the ejection fraction between 5 to 10%, severely reduced. On the other side here, you can see a very thick myocardium. This is hypertrophic cardiomyopathy. The ejection fraction, if anything, actually is hyperdynamic. It's a small cavity. And these patients also can be very symptomatic. Cardiac amyloidosis is where amyloid protein is becoming deposited within the myocardium. You notice that the right ventricle is thick, the left ventricle, and even the interatrial septum and valves look a little thick too. Now, I think that's really important is this bottom right picture here. At first glance, you see that the ejection fraction actually looks normal, and it is. But this would be somebody that has HFpEF. This is somebody actually that has, although their ejection fraction is normal, they have severe coronary artery disease that's been revascularized and continued despite that to have significant shortness of breath, heart failure symptoms, volume overload, ended up with renal failure, and ultimately ended up having a heart and kidney transplant. So this just goes to show you that just looking at an ejection fraction being normal does not tell you whether or not somebody has heart failure or not, and it does not tell you the severity of their symptoms. So when we're treating heart failure, what's our goal? Well, these are the three big things. We want our patients to live longer. We want to improve their quality of life. And in those with left ventricular ejection fractions that are reduced, our hope, of course, with our therapy is potentially to even recover some of that ventricular function. I know this is a very busy slide. This is more for your review. This is looking at the American College of Cardiology guidelines in treating heart failure with a reduced ejection fraction. So this is what we call guideline-directed medical therapy, or GDMT. Not going to go through all this stuff, but I think what's really important is that everybody that takes care of anyone with heart failure at least has an understanding of step one here of using the basic pillars of GDMT therapy in HFrEF. Now, one of the workhorses that all of us use in heart failure are the diuretic medications. And so when I'm talking about diuretic medications, what we're doing in individuals, we're giving these medications to decongest our patient. We make them urinate, but by doing that, not only does it get rid of their edema, it's really what it's doing. It's alleviating the pressures in the ventricle to optimize that Frank Starling mechanism. So the yellow boxes are the workhorses. Really, the one that we use first off are the loop diuretics. You can see that, furosemide, bumetanide, torsemide. And then in some scenarios, we may have to, as we escalate doses, even augment by adding things like acetazolamide or thiazide diuretics. Now, although we use diuretics all the time in heart failure, what's important to know is that these yellow box diuretics really don't do anything to the heart itself. They don't help recover the heart. They don't keep people alive longer. The SGLT2 inhibitors and the mineralocorticoid receptor antagonists, the green boxes, those are pillars of therapy in HFrEF. And so these are the really four main classes of medication when you're taking care of a HFrEF individual that we want to use. So we call these the four pillars of therapy. And what we want to do is try to get, in a perfect world, we would like every HFrEF patient to be on at least one of these, or all four of the pillars at the highest dose tolerated. So we have evidence-based beta blockers as listed below. These are the only three that have evidence behind them in HFrEF. We have ARNI, which is angiotensin receptor neprilysin inhibitor. This is a newer medication over the past decade. The only one available is called sacubitril valsartan. This is the go-to of this pillar. If we cannot use that for whatever reason, we use either ACE inhibitors or angiotensin 2 receptor blockers. Aldosterone antagonists are the third pillar, and then we also have the sodium glucose cotransporter 2 inhibitors, the SGLT2 inhibitors, empagliflozin and dapagliflozin. So our goal is to get everybody with HFrEF on these therapies and the highest doses tolerated. And the reason is because these therapies, through large randomized trials, have been shown to improve survival, decrease heart failure hospitalizations, quality of life, and improve LV function. And you can kind of think of, well, why would these medications maybe work? Back to the pathophysiology, they act against this chronic maladaptive response that we see in heart failure. Now, there's a lot of also different devices that we may use in heart failure. Once somebody is optimized as best as possible in their medical therapy, not going to go into all those devices. There's a lot in investigation as well, too. I think one that's worth bringing up that's been around for a while now is called cardiac resynchronization therapy or biventricular pacing. What some individuals with low EFs have, they actually can develop a left bundle branch block, which causes dyssynchrony in the contraction of the ventricle. And of course, we see our left bundle branch block here with the synchrony. And what can be done then is we put a pacemaker in where a wire is placed on the right in the right ventricle. Another lead is passed through the coronary sinus and lays epicardially on top of the left ventricle. And if we pace both the ventricles together to resynchronize, you see by the EKG, which is now narrow, this has been shown to improve quality of life, survival, and improve LV function in some individuals. Moving on to that HFpEF, so the EF of 50% or more, the therapy for a HFpEF is much different than HFrEF. And what's shown here is that if you look at across the ejection fraction ranges, these are some of the medical therapies that have been tested over the time. And you notice that you got green check marks, meaning good benefit in HFrEF down here on the bottom row. But as you increase and the ejection fraction increases, these medical therapies just not have been shown to have benefit, significant benefit in these trials over the years, unfortunately. And why that is, it's probably because we still don't know how to really phenotype our HFpEF individuals, right? We're basically saying you have heart failure symptoms and your EF is normal. But what's causing it? What we're learning more and more over the years is that HFpEF is probably a multi-system disease. It can be a result of untreated sleep apnea, obesity, renal disease, a combination of all these things, inflammatory diseases. And so when we group all these different phenotypes into one study, well, they almost have like a different pathology. So it's not surprising that these studies looking at these medications have been negative over the years. So our medical therapy in HFpEF is very limited. What I would say is very important in a HFpEF individual is make sure you look for those other cardiomyopathies such as infiltrative disease, hypertrophic cardiomyopathy, amyloidosis, those specific etiologies, because those may have special therapies. But if you've ruled all that stuff out, we use diuretics and SGLT2 inhibitors have been shown to have some benefits. Those are really the two mainstays that we have right now. Nothing else is approved in the guidelines as of this moment, unfortunately. Treating comorbidities is very important. So weight loss, sleep apnea, all the things I'd mentioned before, coronary artery disease is a must, and we have to be aggressive about treating that in a HFpEF patient. And then lastly, I just want to talk a little bit about, we're talking about chronic heart failure, and it's important that we treat this like a chronic disease, meaning that even if someone has a low EF and they get much better with therapy, they even recover their LV function, we, for the most part, really haven't cured their pathology. And what will happen eventually over time is they will start to decline. The disease will progress. And so, although our goal here is to keep them kind of in this like plateau phase that we have in the red circle, at some point over time, they start to feel worse. They end up in the hospital more. They don't tolerate therapies. And if nothing's done, they're going to die from this disease. And we want to make sure that we recognize when they're kind of sliding the slope here and entering this gray zone or this danger zone, because this is where they're entering what we call stage D heart failure or advanced or end stage heart failure. The quality of life in advanced heart failure is extremely, extremely poor, and the survival is anywhere between months to a year. So again, just like making the diagnosis of heart failure is not based on one test, the diagnosis or determining somebody's in stage D heart failure also is not based on one test. We have to kind of look at the whole picture. This is a nice acronym that you guys can use, the I need help acronym. This shows us some of the things that we look at when people are entering this stage. The more of these they have, the more likely they're in advanced stage. So, they start having end organ function, dysfunction. We can't, keep the edema away from the escalating diuretics. We're downtreading GDMT, etc. And what I mean by when somebody's truly in stage D and their survival is poor, this shows a great example of comparison. If we continue with medical therapy in these individuals, median survival is anywhere between 3 and 6 months. It might be a little bit better than right now. This is a little bit older data. But when you look at other therapies, now we turn our attention to, well, things like heart transplant or mechanical devices called a left ventricular assist device, you see the survival is much better in stage D heart failure and their quality of life is improved. So in stage D heart failure, these individuals should be evaluated as, can they have a heart transplant? So easy, makes sense. Cut the bad heart out, put a new one in. A lot that goes into this, and this is hours of other lectures, of course, we can always do, but there's limitations, of course, with heart transplant, right? One, you got to wait for a heart, and that's dependent on a lot of things, the wait time. We don't want people dying while they wait. There's a risk of rejection. There's a risk of a unique form of coronary artery disease called cardiac allograft vasculopathy that these patients can basically develop and die from. Also, they have to be on immunosuppression medications, and those medications to prevent rejection have their own issues, right? They put you at risk of infection, malignancies, and they have a laundry list of other side effects they can cause. The other issue with transplant, of course, is there's just not enough hearts out there. So there's probably anywhere between, around 750,000 people that might have stage D heart failure. If you can see here, within the United States, we only roughly do around 3,000 transplants every year, and that number is not really growing. And so the other therapy that we sometimes look at in individuals is something we can take off a shelf. This is called a left ventricular assist device, or LVAD. And basically what it is this is a surgical pump that we implant. We do a sternotomy, implant this pump into the left ventricular apex. Blood basically just gets pulled into the pump through this tubing called the outflow graft, and it just bypasses the myopathic heart and places it in the aorta. It takes over for the heart. The tricky part about this, of course, is not everything's internal, like a pacemaker or a defibrillator. There's external components. So this cable is tunneled, exits the abdomen, and you can see here that it's covered at all times by a sterile dressing, and the individual has to wear the system controller, or basically the computer and brains of the pump, as well as a power source. So they're hooked up to batteries, and this is 24/7 they have to be hooked up to. But people live their lives with this, and it improves their survival and quality of life. So that's just kind of the spectrum of the way I think of chronic heart failure, and happy to answer any questions.
Thank you, Chris. Any questions from students? I have a couple board questions that I pulled. If both speakers are ready, willing, and able, it might be interesting for the students. Guys, good? Okay.
Sure.
First First one is a pulmonary. 55-year-old female goes to the ED with acute worsening of breathing, increased sputum production, and fever. Blood gases show hypoxemia and hypercapnia. What is the most likely cause of this exacerbation? 1, pneumonia. 2, myocardial infarction. 3, pulmonary embolism. 4, bronchospasms. Or 5, right heart failure.
Looking at that, I mean, you see they're hypercapnic and hypercarbic. So, I mean, you would think about problems with underlying COPD. I mean, we're talking about viral infections, most commonly the exacerbation with that. She's only 55 years of age. They didn't say anything about cyanosis or edema of the lower extremities at all. Did they say anything at all about like heart sounds, split heart sounds, or anything like that to be suggestive of pulmonary
Joe,
hypertension?
this is a board question. And the student is expected to get it right. No, there was nothing said about that. This is a patient that got fever, sputum production, fever, and progressive shortness of breath with hypoxia and hypercapnia.
Okay, so they have an exacerbation of COPD, most likely probably viral in nature.
Right. Most likely, the correct answer is pneumonia, and you're right on. Okay, I'm going to go to a heart failure one. These are actual board questions. So, 68-year-old male with hypertension and coronary artery disease with progressive shortness of breath and edema. He's got JVD, hepatomegaly, and the edema. His echo shows a normal EF, but elevated pulmonary artery pressures. What's the most likely diagnosis? CHF with reduced ejection fraction. Number 2, CHF with preserved ejection fraction. 3, right heart failure, secondary to left heart failure. 4, pulmonary embolism. Or 5, pulmonary edema. Chris, that's yours.
Yeah, so I would say this individual with the hypertension, coronary artery disease, those are significant risk factors for heart failure. And so in that scenario, I would not say that this is, with that, I don't think they're getting at like a pulmonary embolism. And what I would then say is based on the echo said that the EF was normal. So this would be
Yes.
something with, yeah, so this would be heart failure with preserved ejection fraction. Of course, they do have signs of right heart failure based on their exam. The edema tells you that. But again, the most common cause of right heart failure is left heart failure. So I'd go with HFpEF on this one.
Yeah, that's correct. So what he said is a good answer to board questions. The most common cause of right heart failure is left heart failure. Do the students want to do another question? It's up to you guys. Give me a thumbs up or a thumbs down. Megan, I'll pick on you. What do you want? They're wanting more. You guys, see, they want more of you. Okay, I'm going to go back to a COPD question. 65-year-old male, 40-pack year history of smoking, progressive shortness of breath, wheezing, and productive cough. The FEV1 and the FVC ratio is 0.6. His FEV1 is 1.5 liters. What is the most appropriate next step in management? 1, start home oxygen. 2, CT scan of the chest. 3, start steroids. 4, counsel the patient on smoking cessation and pulmonary rehab. Or 5, refer to pulmonary for lung transplant. Joe, you're muted. You're
I'd
muted.
probably say
There you go.
smoking cessation for the patient to begin with.
Yeah. So that's the correct answer. That's the answer that the writer wanted. The first and next step. So that's the key thing here. You want to make a comment about the results of the pulmonary function test, the
Certainly.
FEV1 and
The FEV1 to FVC ratio is less than 70%, so there is obstruction. Then when you look at the FEV1, that's going to tell you the severity of the obstruction. So they have at least a moderate to moderate severe degree of obstructive process. So the FEV1 to FVC ratio is something that people can't fudge. So that's why we go less than 70%. It doesn't matter how much less it is, if it's 60 or 50 or whatever the ratio, that doesn't determine the severity. The FEV1 determines the severity of it. So you get in the game by the FEV1 to FVC ratio, and then after that, you look at the FEV1 to see the severity of it.
Okay, excellent. So again, that's right on what the writer was looking for. Chris, one more. 55-year-old female with known heart failure is being discharged from your hospital. Which of the following medications is most likely to benefit in reducing mortality? 1, lisinopril, 2, furosemide, 3, digoxin, 4, metoprolol, 5, hydrochlorothiazide.
So yeah, so the diuretics, the hydrochlorothiazide and the loop diuretic, the furosemide, have no benefit in mortality. Digoxin has some benefit maybe in reducing heart failure hospitalizations. And now, sorry, for the metoprolol, did they specify which? Did it just say metoprolol?
It just said metoprolol, and it just said
Oh,
lisinopril.
that's tricky. So I would say, based on the absence of information, so I think they're probably going to want us to put the beta blocker down. I think so. The metoprolol, the only thing, unless they're trying to be tricky, is that when we're looking at the beta blockers for HFrEF, really we need to use evidence-based. So metoprolol succinate or toprol XL is the evidence-based metoprolol. Metoprolol tartrate or low pressor would not be the answer. So just in case, but my guess is that they want the beta blocker.
Yeah, well, what they were looking for there was the ACE inhibitor, I think. And if I'd have given you Entresto, you'd have had a better shot at it there,
Yeah.
probably. But I read it as the board question was written, and that's the nature of board questions.
Yeah.
So we don't all get them always right, and that's from the guy who probably writes the board questions. All right, listen, I want to thank everybody tonight. The students are asking for more board review questions, and I've learned that just recently in these sessions. So that's the reason I brought that up. Thank you very much, both. It's great to have experts do these types of things, and I fudged on 4 minutes on the going over tonight. So I apologize, but I hope it was helpful in thinking through board exams. Any questions or comments from anybody else? If not, thank you very much. Everybody have a great night and a nice spring ahead.
Have a good night, guys. Take care.
Thank you.